So I'm going to tell you about a ongoing study through the TB Trials Consortium. It's got the sexy and memorable name of Study 37. It's a randomized controlled trial of LTBI treatment. So many of you are familiar with the TB Trials Consortium. It's in its third cycle. It's a 10-year cycle. It's a CDC-sponsored consortia of different sites partnering with academic and public health programs throughout not only the United States, but the world, in order to trial new TB treatments as well as new LTBI treatments. So Study 31, which is the study which produced the results that have led us to the recommendations to use the 4-month treatment regimen that includes moxifloxacin and rifapentine. That was a product of the TB Trials Consortium. 3HP, our once weekly treatment, was a product of the TB Trials Consortium, and so on and so forth. So it's been very active and very effective and productive for a long time. So the TB control program of Seattle and King County, a couple of years ago with Masa as the PI, put in an application to this program and was fortunate to, I shouldn't just say fortunate, was fortunate and qualified to be included as part of the consortia. And it's actually part of a very small number of sites in the United States. So you can see here on this map, the consortia, which is a 10-year cycle that started in 2021. Although there's a lot of pins in the United States, really the US sites that are independent sites are only Seattle, Washington, Denver, Colorado, and that's it in terms of US enrollment. Now there are VA, Veterans Administration associated sites in Washington, DC, San Antonio, New York City, and Minneapolis, which add to the number of pins. So those are the domestic sites. Now, internationally, we have sites in low burden countries, including across Canada, including Vancouver, as well as Montreal, Australia, as well as a number of higher burden sites that partner either with the Canadian sites or with US sites. So as you can see in this flag, we have here Benin, which is in West Africa, and that partners, in addition to Vietnam, with the Canadian Australian sites, the so-called CAB-V consortia. We have South African sites, both partnering with the VA, the Veterans Administration hospitals in the United States, as well as with the Medical University in South Carolina. We have a Uganda site that's partnered with Case Western in Cleveland, and that's really it. So again, of the independent US sites, really it's only Seattle and Denver. So why yet another study of TB preventive therapy? Well, these are the currently recommended regimens that we have, and the preferred regimens are all include a rifamycin, so they're all rifamycin-based regimens. Rifampin daily for 4 months, rifapentine and INH, that is 3HP, which is given weekly for 12 weeks. A little used regimen in the United States, which is daily rifampin and INH for 3 months. And then alternative regimens are INH daily for 6 or 9 months. Notice that the 1HP, this daily INH and rifapentine, which was studied in people living with HIV in South Africa, is not part of the recommended regimens for a number of reasons. Why then is INH an alternative regimen, and why do we need yet another regimen? Well, this is old. This is relatively old data at this point. There's been many studies that have demonstrated this. The shorter your course of treatment, the more likely someone is to complete it. So here you see the completion rates for 9 months of INH, 6 months of INH, 4 months of rifampin, and the 3 months of INH and rifampin. And your completion rates improve as the regimens get shorter. Now, this is old data, and the 4 months of daily rifampin are really pretty much equivalent to these shorter regimens, but they're all superior to 6 or 9 months of INH. So if we can get even shorter than our currently shortest regimen, which is 12 weeks or 3 months of INH and rifapentine, that may offer advantages in terms of completion of treatment. In addition, our shortest regimen, which here is called combination therapy, this is from this study that originally published the results from that trial, showed that did have higher rates of completion compared to 9 months of INH, and lower rates of hepatotoxicity. But really, compared to INH, 3HP had higher rates of adverse effects. And this was primarily related to the so-called hypersensitivity, the lightheadedness, the flu-like syndromes that patients can develop. And so it would also, in addition to identifying a shorter regimen, it would be nice to identify a regimen that had fewer adverse effects compared to 3HP. And I think most of us that have used 3HP have realized that, in clinical experience, adverse effects related to it are not uncommon. So this study 37, what is it? So study 37 is going to look at daily self-administered rifapentine for 6 weeks at 600 milligram doses compared to standard of care. And standard of care in this setting is defined as any of those preferred regimens from the current guidelines. So any of the rifamycin-based regimens that we all used, 4 months of daily rifampin, three months of weekly INH and rifapentine, or daily rifampin and INH for 3 months. So clearly, 6 weeks is shorter by half than the currently shortest regimen that is recommended. And remember, I said that the 12 weeks of INH and rifapentine do have quite a few side effects. So is using rifapentine actually going to produce fewer side effects? Well, I would say likely for 2 reasons. First of all, it's only 1 drug as compared to 2. There's no INH in this regimen. And secondly, those flu-like, the hypersensitivity reaction that one sees with the rifamycins are actually more common with intermittent therapy. So a daily regimen of rifapentine as compared to a weekly one would, I think, logically be less likely to produce the hypersensitivity type reaction. And the hypothesis here is that the safety and effectiveness of 6WP, meaning just 6 weeks of rifapentine, is non-inferior compared to standard of care using a rifamycin-based treatment. So this is a randomized controlled open label non-inferiority trial, meaning that if a patient enrolls, she or he is randomly allocated to either the experimental arm, 6 weeks of daily rifapentine, or to standard of care, which is decided based on the clinician who's prescribing the medication. Non-inferiority means it's just trying to show that the regimens are equivalent. And open label means that the patient will know which regimen, as will the clinician she or he is on, whether they're on the rifapentine regimen or on the standard of care. The setting is countries with low to medium TB incidence. So not all the countries that you saw put up on that map are going to enroll patients at present. This will exclude South Africa, Vietnam, and Benin. The regimens we've already discussed, and there's 2 primary outcomes. One is 6WP safe? And that requires a smaller number of people to identify that. Now, it's the same people that are going to be used to identify safety as effectiveness. So 1,700 people will be enrolled into each arm of this trial for a total of 3,400 individuals. Again, the safety, as I said here, is looking for adverse drug reactions. And the effectiveness will be looking for following patients for development of TB, for those who are adults following for microbiologically confirmed TB, and for those who are less than 18 years of age. So anyone older than 12 years of age is eligible, will be following for either microbiologically proven or clinical TB. And this follow-up period, patients will be enrolled for a total of 2 years. So there'll be about a year and a half of follow-up in all individuals to assess them for the development of active tuberculosis. Here's the study visit structure is the main reason I'm putting this up here. So in-person visits, while the person is on treatment, there's 3 in-person visits after enrollment, 3 to 5 actually, depending on the length of treatment, which you can see here. So 3 for the experimental arm of 6WP, and 4 to 5 for the standard of care arms. And then there's follow-up that's mainly by phone, going out to 2 years of follow-up in order to assess for the development of active TB. So who's eligible for this study? Well, inclusion criteria includes people who are not pregnant or breastfeeding and are 12 years of age and older. Now, if you are a person living with HIV who has close contact to someone with infectious TB, then you're eligible for enrollment regardless of your skin test or IGRA result. For everyone else, you have to have logically either a positive TST or IGRA as evidence of infection with latent TB, what we use for our own, base our own recommendations of treatment on, and who are at increased risk of progression to TB. So this is the key thing. So remember, we're going to ask you to keep the study in mind when you see patients who may be eligible and consider referral. So who's at increased risk of progression of TB? So household and other close contacts, and that's if you're in a typically in a local health jurisdiction, you may come across these patients. That won't be the majority, I believe, of clinicians who will be able to refer to our study, but that is one of the enrollment criteria. Evidence of recent tuberculosis infection, so not necessarily a known close contact, but observed to have a conversion of their skin test or IGRA from negative to positive, which occurred within the 2 years prior to enrollment in the study. Someone who has HIV co-infection and has evidence of LTBI is eligible, regardless of how long ago they were considered to have acquired LTBI. And if you have LTBI and an area of fibrosis on the chest X-ray greater than 2 square centimeters, which is increases your risk for progression to TB, that is, you are eligible for enrollment. Now, recent immigrants to the United States who have an abnormal chest X-ray are also eligible for enrollment. And you may come across patients who fit this description. I think the most common group who would be eligible that you all in the ECHO community may see are someone who's recently immigrated within the past 2 years from a country with an estimated incidence rate of TB at 150 or per 100,000. And at the end of this presentation, I'll share with you the Seattle King County website that has the full list of countries. But I've put up here some of the countries that I think are, at least in my experience, are common, where there's people from those countries are commonly live and are seen in the Seattle area. So this includes people from Afghanistan, Bangladesh, Bhutan, Cambodia, Congo, Ethiopia, Gambia, India, Kenya, Laos, Marshall Islands, Myanmar, I left off the R, otherwise known as Burma, Nepal, Nigeria, Pakistan, Philippines, and Somalia. Due to an error on the CDC's part, they left off Vietnam, but we're working to rectify that, and we expect shortly that Vietnam will be included in this list. And then finally, someone who has LTBI and has a medical condition that increases risk for progression, including end-stage renal disease, either on renal replacement therapy or with an elevated or decreased GFR. Someone who's on chronic steroids that is at least a prednisone dose of 15 milligrams per day for greater than 2 weeks, and someone who is currently or planned to be on TNF-alpha inhibitors. So exclusion criteria you can see here, basically anyone who's suspected of actually having TB or was exposed to someone who had rifamycin-resistant TB, as we wouldn't expect these regimens to be effective treatment for that. Any history of treatment for TB within the past 2 years, or LTBI. A history of completing treatment for active TB or LTBI. A history of allergy to rifamycins, baseline liver dysfunction, or someone who's on medications that are not compatible to be given with a rifampin or rifapentine, and frequently that includes antiretroviral therapies. Finally, anyone who's pregnant or breastfeeding or planning to get pregnant, or anyone whose weight is less than 25 kilograms. Remember, the minimum age for eligibility is 12 years for this study. So here's some question. What's the cost to the patient? This treatment is provided without cost to the patient. So I think that could be a patient benefit to referral this treatment to the study. Refer them to the study, and they are evaluated for enrollment. And if they enroll, then their treatment, their chest X-rays are provided without cost, and they are also given incentive. So what testing do you need before referral? Well, either a skin test or IGRA that's positive, and if you have multiple ones, as long as at least one is positive, means that the patient is eligible for referral. And a chest x-ray prior to referral is not required. So you can just go ahead and discuss it with the patient and contact us and let us have further discussions to see if they'd be interested in enrolling. What if you refer a patient who then subsequently declines treatment? Will we just send them back to you? No, those patients will also be managed and treated for free regardless of their enrollment status. So again, that benefit will remain to people who are referred for the study. How long will participants be in the study? How many visits are involved? Well, participants will be in the study for 2 years of including the follow-up period to evaluate for TB. The visits, I said, in person after enrollment are between 3 and 5 while they're on treatment. And after that, mostly for the vast majority, any follow-up can be completed just via phone call. And then where to find out more? Go to the King County TB program website under Research and Projects tab. Let me see if we can try to, I don't know if we can try and paste that or put that in. Joseph, if you have the chance to put that in the chat. You can go direct to the site by clicking on that URL. You can contact that phone number, that's the general line, or you can contact us via email. But certainly please visit the study, and we can get you out a short summary of eligibility criteria to help you when you're actually seeing patients. I think with that question,